first live stream. Thank you for joining us remotely. We're about to start. And actually, I could probably, everyone! Okay. Hello, everyone. Welcome. If you do want to grab a refreshment right before we're going to start, we have all our guests here. My name is Dr. Takrim Michelle Picado, the Executive Director of National Science Policy Network. Thank you so much for joining us in lovely New York. This is part of our series, and I am going to just say thank you for coming and pass it off to our student leaders that are going to be speaking more. 1 second. Oh, you're permanently standing up there? We're working okay. You do you.
Hi everyone, my name is Ariel and I'm a graduate student who has been engaged with the National Science Policy Network, a community of scientists and science policy enthusiasts engaging in policy making since 2023.
And hi, my name is Mia. I'm also a graduate student. Been engaged with National Science Policy Network since not too long, just 2024, last fall. We'd like to welcome you all to the New York location of Politics Aside, Policy Forward. This is an event series. The series is designed to engage the general public, scientists, and decision makers on important topics. Our next events will be on healthcare innovation, efficiency, energy, and transportation issues.
And today's event is titled From the Underground to the Mainstream, the changing landscape of psychedelic policy, where we will collectively examine the science and policy of psilocybin and the broader conversation around legalizing psychedelics from medical or recreational use. In this discussion, we'll also discuss medical supervision and the societal impacts of legalization.
And we have an amazing set of panelists here. Thank you guys so much for joining. So we're going to hear from a few different panelists, and they all have different perspectives from psychedelics. And now we're going to introduce them. So first, we have Senator Nathalia Fernandez. Nathalia Fernandez is the New York State Senator for District 34, representing the Bronx and Westchester. As the chair of the Senate Alcoholism and Substance Use Disorders Committee, she is a leading voice in the fight against the opioid crisis. Before becoming a senator, Senator Fernandez served as a community director and chief of staff in the New York State Assembly, as well as the governor's Bronx representative. Elected to the Assembly in 2018, she has championed education, mental health, social justice, and women's rights. As the first Latina to represent the 34th Senate District, she continues to advocate for working families, seniors, and marginalized communities, striving to make a difference in the lives of her constituents. Next on the panelists, we're just going to go down the line, is Dr. Amy Lehrner. She is an assistant professor in the Department of Psychiatry and associate director of the Parsons Research Center for Psychedelic Healing at the Icahn School of Medicine at Mount Sinai. She is a researcher, therapist, trainer, and supervisor on clinical trials of MDMA and psilocybin-assisted therapies for PTSD and other conditions in veterans and civilians.
Next on the panel, we have Brett Waters. He is an attorney and co-founder of and executive director of the Reason for Hope, and a co-founding board member and counsel of the Veteran Mental Health Leadership Coalition, and a member of the advocacy committee for the American Brain Coalition. Brett is a multi-generation survivor of suicide loss. His work focuses on law, policy, and advocacy to increase research funding, reduce unnecessary regulatory barriers, and safely expand access to psychedelic and other breakthrough treatments for mental health and suicide prevention.
Dr. Michael Gentile. He runs a private practice at Wyckoff Wellness Center, where he specializes in child and adolescent psychiatry, addiction psychiatry, and forensic psychiatry. He is a proponent of medical cannabis, ketamine, and upon legalization, the availability of psychedelics in conjunction with therapy. Dr. Gentile currently serves on the Member Medical Advisory Board at Breakwater Treatment and Wellness in Cranbury, New Jersey. He's also a member of the American Society of Ketamine Physicians and the Society of Cannabis Clinicians.
And lastly on our panel, we have Alison Hoots. Alison is an attorney specializing in advising about psychedelics and other controlled substances in the U.S. She has unique experience advising in all areas of the psychedelics ecosystem, including practitioners, as psychedelic-assisted therapy providers, risk reduction support service providers, ketamine practitioners, therapists, and churches. She's a founding member of the Psychedelic Bar Association, head policy counsel for New Yorkers for Mental Health Alternatives, and executive director and board member of Sacred Plant Alliance. And before we dive into the rest of our program today, we would like to thank our sponsors for this event. The National Science Policy Network is our presenting sponsor. NYU and the Chemist Clubs are our hosts. And then Research America, Journey Clinical, Press Day, Psychedelic Alpha, and Curious Elixir are also sponsors for this event.
Okay, yeah, so how this is basically gonna go is we are gonna start with the senator. Just gonna give a spiel of some of the steps. So you wanna come up? Or you can get them right there.
Or I'll just put it right here. Good afternoon, good evening, everyone. I'm State Senator Nathalia Fernandez. As been said, I represent the East Bronx and a little bit of Westchester County. And in the State Senate, I chair the Committee of Alcoholism and Substance Use Disorder. And I start out by saying that it wasn't always called that. We've changed the name to Substance Use Disorder because before it was substance abuse. And that's part of the greater battle when dealing with this conversation, the stigma that people are trying to hurt themselves. So just changing the title alone has been, a change in, I guess, the mission of this committee as I see. As the chair, I've learned a lot. Of course, I've seen the crisis at hand. I know a lot of us can say we've seen those struggling out in the streets, but a lot of us have also experienced family members, friends that have struggled either openly or in silence. So this has definitely been a wonderful experience in many ways, but also a heavy one, dealing with, the sadness of it. But as chair, I've really tried to indulge myself with all communities involved, those in recovery work, those in harm reduction work, even talking to those that believe in abstinence, and really trying to understand what we need. And what I knew coming in, and also firmly believe now, this is a public health crisis, and it must be treated as such. And it's a tough conversation a lot of the times because everyone wants to put politics in play, what you need to do, what you're supposed to do, what it should be, and what we shouldn't be talking about or providing to help the cause. So it's something that I really enjoy, and I'm grateful for this position, to be that voice, to be that position of reasoning, to bring facts and science into the conversation, and to really try to push New York into a direction that would continue to treat this as the health crisis that it is, to remove stigma and normalize the conversation, and to make sure all communities have access to resources. So thank you for having me today. I'm very excited for the conversation, and I'll give back to our moderators.
Thank you, everyone. And so to kick off today's conversation so that we can all have the same set of definitions, I'd love to have members of the panel just speak from your experience about describing what psychedelics are and what their therapeutic potential is. I know we have some experts on this panel who do work in this area, and so I'd love for you to just give us a little definition for the group.
So, anyone? Is it on? Excellent. It doesn't even sound echoey to me, so that's great. Okay, so psychedelics is a kind of umbrella term. Psychedelics means mind manifesting, and it's a term for that is used, as I said, in this umbrella way for a variety of different substances, which is important to recognize they are different, and they have different aspects of what they evoke in people, and also different kind of medical and chemical properties. There are classic psychedelics, what are considered classic psychedelics, so those are things like LSD and psilocybin that are mostly believed to work through the serotonin kind of pathway. There are also a variety of different substances that are kind of considered non-traditional psychedelics, which include drugs like MDMA and drugs like ketamine, which are considered sometimes in this conversation psychedelics, but ketamine is really more in the dissociative category. MDMA is considered an empathogen or entactogen, and they have different effects on people subjectively as well as medically. So when we're talking about psychedelics, it can be helpful because many psychedelics are being studied for a variety of different indications, and we'll talk about that. But we're also talking about more than one class of drugs and a variety of different substances, and I think it's important to make sure that that's part of the conversation.
Michael, do you think you want to add?
Well, speaking, I'm a ketamine provider. I run a ketamine clinic in Wyckoff, New Jersey. I've had a lot of experience. I've been utilizing ketamine as an effective medication in my practice for about 5 years now. I've supervised thousands of infusions. Ketamine is, I would say, if you compare, I guess, the classic psychedelics to ketamine, the classic psychedelics, as you mentioned, work through the serotonin pathways, whereas ketamine works with another neurotransmitter called glutamate. Ultimately, they all do the same thing, though. They lead to the release of what we call the brain fertilizer, BDNF, brain-derived neurotrophic factor, that produces effects on the brain, including neuroplasticity and neurogenesis, so brain cell growth and connection, which we don't know what actually is the reason why they work, but it's postulated that this may be the reason, in addition to possibly anti-inflammatory effects. Ketamine, I think, is a little lighter, gentler than the classic psychedelics, LSD, psilocybin, which can be a little challenging during treatments or use. Ketamine, as mentioned, is a dissociative anesthetic. It's a Schedule 3, so the classic psychedelics are all Schedule 1, which means they're judged to be highly addictive and no medical value. Ketamine was spared from this. It was an effective, back about 1968, 1970, it was an effective battlefield anesthetic in Vietnam. And that's what it's approved for. It's approved for anesthesia. There's a commercial product called Spravato, just approved, which is an isomer of ketamine. Ketamine is composed of mirror images of themselves, a left and right molecule, and one of them they separated out. It seems to be more potent. It's a commercially available product which is approved for treatment-resistant depression, and I think unipolar as a sole monotherapy agent for depression with suicidal thoughts. I think that's a new FDA approval. So, yep.
Thank you.
I think another interesting interpretation.
This one, this one,
Hello? Yes. Another interesting interpretation of
feedback, you said, what are they being used for? So maybe just speak to that for a second. And I think it's important, well, there's many things to kind of say about psychedelics and research and their use, but just to say that right now, other than ketamine, because of the approval that you described in esketamine and Spravato for depression, psychedelics are not approved by the federal government for use, nor have they been deemed safe and effective by the FDA. That's kind of just where we are right now. So one thing that's important to know is that there is a lot of enthusiasm and excitement about what these drugs might be able to do, but that is really ahead of kind of what the research shows. So just to say that in terms of research, which is the only, well, I won't say that because now there's legality in different states. So there's these different pathways, right, to using these substances. But in terms of using them for mental health and as a medical treatment, they're being studied for a variety of different indications. So the phase 3 trials, which are the most advanced trials, are basically studying psilocybin for major depressive disorder, as well as end-of-life anxiety. And there have been studies with cancer patients, and MDMA for PTSD. Those are the two kind of most far ahead in terms of the evidence base. And there are a variety of other indications that are being investigated right now with a variety of different substances. So substance use disorders, things like LSD and Ibogaine. It's a whole conversation about using drugs to cure a substance use disorder, but there's a lot of promising data there. There are research trials underway looking at other mental health indications, things like OCD, eating disorders, a lot of interest. And then there's another line of research looking at neurological disorders, so things like Parkinson's, and questions about treating people with dementia. And then you mentioned the anti-inflammatory properties that are starting to be investigated. So there's also trials looking at kind of long-term autoimmune or inflammatory disorders like Lyme disease. So these are all kind of emerging lines of research, and the data is still forthcoming. We're still learning.
I'd like to ask a follow-up question to you, actually. So these are emerging lines of inquiry, and so my next question is, if they were to be eventually implemented formally within like a therapeutic setting, in a paper in an editorial that you wrote like few years ago, you had said that there's a reimagining needs to happen in terms of how health is provided. Would you mind speaking to us about what that reimagining would entail specifically? Yes.
Yeah, so what we were saying in that article was that there is a real possibility for a paradigm shift in mental health. So again, I'm talking right now about psychedelics as mental health treatments, so separate from psychedelics for other kinds of self-expansion or exploration, right? And I think that psychedelics, if they prove to be as effective or even close to as effective as what we're finding in our early trials, they really do pose, I think, an opportunity for us to rethink and reimagine what mental health care could look like, because we've never had a treatment. So when we talk about is psychedelics, are they effective? The way we work, I think, and the way we think about this, probably everyone here will agree, is that we are not thinking about psychedelics as a drug that is the mental health treatment. We are talking about psychedelics as a drug or a compound that catalyzes a mental health treatment process. And it is together having a drug in the context of a psychotherapeutic container that seems to be the most promising for real recovery and healing. And that is brand new, because we have psychiatry that prescribes drugs, we have mental health providers who do psychotherapy. We don't have any treatments that depend on the two. Sometimes we collaborate. You prescribe one thing and we talk about our shared patient, but this is actually an integration of a medication into a psychotherapy process. So to me, it doesn't even make sense to say, does the drug work? It's does the psychedelic assisted therapy, it's a package, does that work? And if it does, then we have to rethink how does mental health treatment get provided. So in some cases, it's a real challenge to our system, because we have, should I bore you with billing codes? We all have to, everyone has to get paid, like you have your 1 hour session with your patient, or the doctor has their 15-minute med management. So if I'm doing MDMA assisted therapy with someone, I have a 8-hour session, that's my day. You know, we're gonna sit down, they're gonna take a medication, and we're gonna be together that whole day. And then there's a variety of rapid integration sessions, and those look more like traditional psychotherapy. Some of these models involve pairs, psychotherapy pairs. So kind of how do we organize our treatment systems to make that work? It gets kind of complicated, but I think there's this incredible potential if we can figure out, you know, how to kind of change the model, not just in how we deliver, but how we think about what we're delivering. I have a PhD in clinical psychology. I am sorry to say that in my training, I've never heard anyone say the word recovery or even healing, ever. I actually really never heard anybody say that word until I entered the psychedelic space. And I was like, it was almost like a surprise when I heard that at the beginning, because in my training, it's like we try to help people manage symptoms, or maybe we try to, you know, we measure how their depression with a scale or something like that, but these substances really seem, for the people for whom they work, and they don't work for everybody, but for the people who really are able to make use of these substances, we are talking about healing and recovery, and I think that is new in mental health, unfortunately.
Makes me want to pivot to ask Senator Fernandez about Senate Bill S459. Would you care to share the room about that bill, please?
Yes, that is one of my bills that I've introduced. I introduced it in my first year as a senator, and it was proposed to me by one of my colleagues in the assembly. This was something that it's from Assemblyman Pat Burke, he's up in Buffalo. And upon me getting ready to enter into the assembly, he was into the Senate, he was like, oh, I got a bill for you. Then I entered the Senate, I became the chair. So he's like, this is the perfect bill for you. And I'm not gonna lie, when it was first presented to me, let's create a pilot program so we have medicinal psilocybin. I'm like, medicinal magic mushrooms? Do you want me to leave my seat? Like, I'm not gonna get elected again. But, you know, really hearing the research, the advocacy, the groups, the people that have been affected and pushing for this, and having a few meetings from individuals with various different experiences, veterans who had PTSD, first responders, Joe the fireman, I have to remember him, and I swear I gotta fight to not cry because his story was so compelling about how his experience from 9/11 caused him to develop depression. What is it? What's the guilt?
Cluster headaches.
Well, I'm getting there. He ended up getting cluster headaches. I didn't know what cluster headaches were, and it is probably the most painful headache that anybody could ever experience. There's been stories of people literally killing themselves because of how painful it is, and he's tried everything under the sun, from therapy to hypnosis to opioids to everything, and it just didn't work. He tried psilocybin, and he finally got a good night's sleep, and literally changed his life. So those stories inspired me to be brave and to put this bill in, because there are people that need this. You know, if anything else doesn't work, this is something that has been proven to work by their own testimony. So this bill is a pilot program for our veterans, first responders, and you know, many could say that that's a safe target audience. You know, our veterans, who's ever going to go against our veterans, and we still always need to do more for our veterans. And this is something that has been studied, not enough in New York State, so that's another area that I want to pursue to see that we can get some research funding to allow this practice to start, that this is a medicine that can be given, monitored, and give people that second chance of life by relieving them from the suicidal ideations, from severe depression, from PTSD, from everything you can think of. So the bill right now, I'm hoping to see it pass through at least a committee, because I believe it goes to the health committee, and in the process of a bill, it has to go through health committee before getting to third reading, which allows it to get to the floor, to get to a full floor vote. But there's so much conversation that happens in between, and I'm still educating a lot of my colleagues, and thankfully a lot have signed on to the bill just from conversations from last term into this term. And you know, for bills that are controversial, and I think New York is still in a pretty green space when it comes to psychedelics, you know, I think this is a smart first step into getting psychedelics into medical spaces, into the medical conversation, and to have a pilot program available to see, you know, what it can do and the potential that it has to saving lives and really helping people.
Thank you. And to build off of that, Brett and Allison, as folks who are both advocates and legal practitioners, how do you see the current legislation keeping pace with or falling behind developments regarding to psychedelic science and therapy? Just to build off of that.
So it's a very interesting dynamic with the, psychedelics as being mentioned, Schedule I controlled substances. They are subject to the highest barriers to research of any controlled substance. It's very difficult to do these studies, and even though things like MDMA, assisted therapy, breakthrough therapy designation for PTSD, meaning it shows through clinical trials that may be as or significantly more effective as anything else on the market. There are 3 different psilocybin drugs that have breakthrough therapy designation for treatment-resistant depression or major depressive disorder. An LSD-based drug has it for generalized anxiety disorder. So we're seeing all this promise, but it's very difficult. It's very expensive to do these studies. So I think there's the natural inclination when you see all of this promise and there's so much potential, but it feels also so far away. To get these approvals, and once something is approved by the FDA, it would then have to be rescheduled by the DEA, and that's when, and also at the state under State Controlled Substances Act. So that's when you'll start to be able to see the traditional medical system prescribing these substances and be able to access them through the medical system, ideally through insurance with insurance coverage. Otherwise, it's going to be a really rocky road moving forward, and really, in particular, incentivize more of some of, I think, what you're getting at with the legislation going on, and particularly at the state level, that is following somewhat in the footsteps of cannabis, and trying to create other methods of access, whether in Oregon through a ballot initiative initially passed a system that's not medical, but it is a supervised system that doesn't require diagnosis or medical doctors, but it requires it to be done within supervised clinics and with certified essentially facilitators that are supervising you. There's a slightly different system that's kind of a mix of a little bit more clinical and also similar to Oregon, that just coming online in Colorado after a multiple-year rulemaking process. New Mexico just passed legislation to create, which I think was the natural next step that we were going to see from cannabis, which is like a quasi-medical system. It's called, I believe, the Medical Psilocybin Act, but it's again, using natural psilocybin. It's not going to be, the drugs have been regulated by the FDA or studied in clinical trials. It's not going to be prescribable. You won't be able to access it through the traditional medical system and insurance coverage, so that'll really limit the market, particularly for Medicaid. Federal dollars can't be spent on a product that violates federal law, but it's still creating systems of access that right now, the FDA and DEA have kind of, just like they did with cannabis, sort of let this progress, and it is creating certainly many more points of access. And we also know there, and Alison can speak on this, there's a lot of religious use and underground use as well, that once people know the promise, the trials, especially for the naturally available substances, it's there's no really putting the genie back in the bottle. So I think education and harm reduction issues are really important as well, so people at least are operating as safely as they can be, because it's I think a lot of people see the potential, and someone coming from a multi-generation survivor of suicide loss, I was so inspired getting into this work by the veterans, people like Jess Gould in the audience here, and other veterans that we work with, taking people outside the country or underground, doing whatever they could to help their friends or family, find relief, because they were desperate. They feel like had time to wait. They couldn't access a clinical trial. And so I very much understand the desire to create other forms of access, and I constantly have people reaching out who are similar, who come from suicide loss backgrounds or are themselves suicidal, or they're on multiple medications, and it's a very tricky patient population with try to refer people to trials with like really experienced practitioners who especially like be able to manage the different medications and other things people are on. So, government funding to get more of these studies going has been a major problem for a long time, and now we're starting to make some progress on that from both federal and state level studies. But it's it's when you see the urgent need and you see the promising data, it's very difficult to, there's not one easy right answer or way to go. I think Alison could speak much better than some of these other legal structures.
I think you did a really nice job, but I think I just emphasize how cumbersome these systems are. The federalism aspect that states can legalize, but it's still federally illegal. And this ends up tying the hands of anyone with a DEA registration, which is pretty much most doctors who can prescribe, or anyone doing research, a nurse. And so they're, part of their registration with the DEA says we agree to abide by federal law. So it's very hard, if not impossible, to get them to participate in the state models. So even where there is access at the state level, some of the components that would be very helpful, like screening from a healthcare provider or even preparation with a therapist, may risk a DEA registration, their license. And so that's really hard. And we know that what happened with cannabis was, despite the federal prohibition, they brought in these medical cannabis programs. And HHS actually looked at the data from those state programs that were federally illegal and said this actually shows medical use, that it has a medical use. So it's interesting to see that that conflict actually resulted in something that might affect federal rescheduling. And the other component is people are using these substances. You can buy bars that say they have psilocybin in them in most stores. They may not even have psilocybin. People are providing these substances in spiritual contexts. Safe supply is really important. Screening is really important. Continuity of care, especially for people who are veterans or have very serious health conditions, need that constant support before and after. That may not be accessible, but it's still happening. And so by legalizing, by regulating it, it actually increases safety. It allows people to call for emergency services if something does go wrong. And the issue is really, nothing is changing in the underground, as they call it. People are still engaged in these services, providing support like harm reduction, which is like trip sitting, basically. Or these religious organizations who sincerely believe that a substance has a very spiritual and sacred meaning to their religious practices. And there is actually a lot of case law and a framework for exemptions for religious use, which I'll get to right now.
It's really interesting that you guys are talking about cannabis legalization. I think there's a lot of similarities between psychedelics and cannabis legalization. I wonder if any of you can speak to like how the legalization of cannabis is affecting like how psychedelics legalization is moving towards now, and if it's faster because of it, or if there's similarities in terms of like science pushing that policy. And so that's my question.
So the journey that we've been with cannabis on a policy level has been long fought, very long fought, and I think the science has helped us get to this point, because the science opened up the conversation as to why medicinal cannabis is needed, how much is being used, how there is success there. So when New York legalized medicinal cannabis, it created a control, and I think that's a general comfort that the public can feel, that okay, if a doctor's saying that this is okay to use, then we're okay to use it. That certainly was the kickstart to just general interest, knowledge, studying, even the conversation into recreational use, which ultimately got us to the point of passing the MRTA in New York and legalizing it with purpose. We really wanted to make sure that cannabis in a recreational use is going to what was it? It's going to help correct the wrongs that we've had in the past. You know, there definitely was a social justice aspect to this, making sure that the funds that we've generated are going to go back to communities that have been hurt by the over policing and over arresting of cannabis use. So that all in all has, I think, allowed us to now talk about other substances that have medical purpose, have medical successes, but then also entering into the recreational use. So that is reason of why I started this way, because I feel like the baby step is a safe pace to take in showing how it's, not just a drug that people are using to have fun with, or something that is actually dangerous. And it's also been hard because with the legalization of cannabis, we've all seen the illegal pot shops, smoke shops everywhere that are not licensed, that are not, paying into the system. And unfortunately, with the raids that have happened, because as much as I'm so proud that we've, legalized marijuana, it's been very frustrating to have to deal with the illegal stores that are opening up right next to schools, that are not, checking IDs, that are selling gummies and things to children. Like, these are real stories. And it's been tough to turn the conversation to say, okay, well, now let's do this, the same thing that we just did with psychedelics, and the fear mongering comes right back in. Oh, well, look, our kids are gonna get their hands on it, they're gonna use it, it's causing them to do this, it's causing them to be like that. So that's been a constant battle that I've experienced, talking about how, we can't let that fear stop us from the progress of providing a real help to people. And it's not been good either that in these stores that they're selling cannabis illegally, they're also selling, mushrooms illegally. So I think that, in a way, is kind of holding us in this fear position, much where we were at the beginning of the cannabis talk. But I do think that it is carrying the conversation about understanding it more, why people are interested in it. That's a big reason that we don't talk about enough. Why is there interest, and what is the goal of using it? And many people, yes, the goal is to be better, feel better, be healed. And others maybe a different reason. But did I ask a question? Did I ask a question? I don't want to ramble. I could ramble.
That kind of brings me to another question that I wanted to ask, but I'm gonna pause and not ask it. So now, actually, Brett, I wanted to ask you about what does meaningful community involvement look like in terms of crafting or contributing to psychedelic policy, in terms of giving input as a person who is maybe being affected on a personal level and want to affect change on a policy level? How would a community member go about that process, if that makes sense?
Sure. So I guess I kind of view it through a couple of different lenses with my work. Sometimes there are just community-led efforts in different federal or state level work that maybe just reaching out for a legal opinion or advice on certain language, and even if it's not something that our organization necessarily is focused on or actively involved in any sort of advocacy work in a particular state, but I'll just get requests for legal support or other kind of reviews. And then sometimes it's for reaching out to particular patient populations, whether it's the veteran community, people from suicide loss backgrounds, people who've lost children to overdose, and other severe trauma, or different. Obviously, there's a lot of advocacy that is built around different particular patient populations, and so we do try to get a mix of as many, I guess, patient population perspectives, especially in the medical related work and the research related work, really get that patient perspective, but then also we work with researchers, clinicians, and try to get and certainly plenty of other attorneys and policy experts to try to get a broad mix of input for different legislative or documents. I mean, sometimes it's very boring things like responding to FDA clinical trial guidance, and it's not the most exciting things in the world centers, but it is, very important for kind of the long-term trajectory of research and things that can impact access to these substances in the future.
And Michael, as a practitioner, who are your patients in terms of demographics? Who are you seeing in your work?
Well, I treat across the lifespan, from children to elderly people. I've treated patients with venous ketamine as young as, say, 14 years old as 80 years old. I mean, it just depends on the diagnosis, what the ailment is, why they're coming in, what their situation is, why they're using it. These are mostly patients who have failed the traditional, the orthodox treatments of antidepressants, and are looking for an alternative, possibly a complement to the traditional medications. Most of my patients, I use ketamine as an adjunctive treatment to the traditional medications that we have available. I would say few are just coming in just for the ketamine. It's an art. It's a way to you don't want to give back the gains we've made with traditional therapies, which are, the effectiveness is not very robust. Statistics are approximately 30% effectiveness for antidepressants, which is not good. Not good if you have high blood pressure, if you have diabetes, if you have cancer, you wouldn't accept that. Ketamine and hopefully psychedelics are showing at least 70, maybe 80% effectiveness. So very robust effectiveness with the psychedelics. So they are very promising. I would say, Amy, going back to what you had mentioned about looking at psychedelics differently, I think a lot of it has to do with how they work and the mechanism of action, how they actually correct the root cause of depression, where we used to think it was chemical imbalance. We used to call it the monoamine oxidase, monoamine theory of depression. There's been some influential studies, analyses that have almost debunked this now, and we're starting to learn more about different pathway circuits in the brain. Particularly, if you're interested in psychedelics, you would want to know about the default mode network that psychedelics interrupt this background chatter and rumination that we all kind of have that can be negative at times. And we're taught our self-language is negative, and that seems to possibly lead to depression and anxiety, where the psychedelics seem to disrupt this in a way, and give people a new perspective and a reset and a new way to think. So.
I have maybe a simple question. Why is it a ketamine clinic? Like, if all these other psychedelics are showing really promising effects to mental health disorders, then why ketamine? And I don't know if that just goes back to like New York or New Jersey state law, but
No, that's a federal
okay.
legality. So ketamine, as you mentioned, esketamine is like an FDA-approved nasal spray, but ketamine has been FDA-approved as an anesthetic for a very long time. So it's not a Schedule I drug, and there's something called off-label use. If there's a particular amount of evidence, supporting the use of a drug for another indication, doctors can prescribe it off-label, and unfortunately, like, often that's not covered by insurance, and so people have to pay out of pocket, and that has been a major issue in, I guess, the ketamine clinic space. It's a resource-intensive treatment. It's not just like being prescribed an SSRI and going home, and that's the way that psychiatry, unfortunately, has worked for a very long time. Has been to some extent, it has been very basic medication management. This is a new paradigm, effectively, treatment, and I think getting back to the kind of more collaborative care and Colorado and, how that impacts, or the future of ketamine clinics, I do believe that it will be, or I hope, and what we, would like to see is, the infrastructure that ketamine and esketamine is building will, once MDMA is approved, or many FDA approved, once psilocybin, these other drugs, like, most of them will be brought within these, clinics. There are also other, emerging interventional psychiatry type treatments like TMS and other more intensive therapies, things that have, they're more time intensive, they're powerful.
What is TMS?
Transcranial magnetic stimulation. And there's a whole lot of similar treatments that have very confusing names, and there are, lots of acronyms, but I think the future of psychiatry and mental health care is going to be, more, hopefully, more combining of psychiatry and counselors and therapists and nurses and a whole range of practitioners working more collaboratively with a variety of different treatments and hopefully not going to, a shift away from what we have seen in the last 40 plus years in mental health care. So I'm excited that is coming. We are going to see more, clinics integrating all of these things and more integrated, networks of practitioners and also, combinations of telehealth and other forms of community support that will be able to help deliver these treatments. Because while I agree that therapy is, or some form of psychosocial support is like really critical, these are powerful, treatments. Exactly what kind of therapy or support, how much, there's still a lot of questions that are left to be answered, and so I think there's, hopefully we'll see more funding to answer those questions, and but the future I do think is going to be more of these collaborative clinics with a lot more treatment options.
Yeah, so we're gonna turn to audience questions. We're gonna borrow Mike.
Okay, questions from the audience. This is your time to shine. We've learned that it's complicated, but there seems to be promise, and a stat that, traditional treatment, especially for treatment-resistant depression, see, I'm listening to you, it's not my subject, seems to be therapeutic. There seems to be press for destigmatization, and that it's working in the lab, and that it's working with real people. But I think we're going to open it up because I know that, Alison, especially, you're working on something right now, so why is it so hard? Let's see. I'm going to go down this row right here, because you three.
Really interesting. Thank you guys for that, for adding color to this conversation. So you kind of touched on a little bit, but didn't directly call out what would be potential barriers to access for treatments like this. Obviously, putting the cart ahead of the horse here, the first thing is policy solutions for legality as well as descheduling. But once these treatments are available, how do we ensure that access is equitable, particularly in a rural health setting, where you don't often have access to a clinic where you could have a practitioner oversee your care? Especially considering the fact that when you look at prevalence, depression is much higher in rural areas, and again, we're seeing a lack of access to care. Cost is another barrier to care. If these treatments are not covered by insurance, or especially Medicare, which again is higher in rural areas, just ultimately, after legality, after descheduling, what is the policy solution for equitable access?
I just want to respond, which is that I think not descheduling, because if they're descheduled, they're not medicines and people can use them for any personal purpose, recreational, communal, religious, etc. If they're rescheduled, brought off of Schedule 1, then it could be used in a medical setting. And I agree, I think there's a lot of problems with access to medicine and healthcare in general. I think it's the same exact issues.
To speak about access, unfortunately, it's political too, especially in rural areas. I feel like in dense communities like New York City, you would have noticed that a clinic probably opened up in your block sometimes. But in more spacious, less dense communities, if there is a business opening up or a clinic opening up, there will be opposition, because again, that stigma is just like, oh my God, this is going to hurt our community. We're going to bring people here that, are not from here, and the degenerates, like the worst things you can think of, that people say about each other, and especially those suffering, it's said. And what happens? They go to their local legislators, you have to stop this. Then the local legislators, how can I stop this? And it's happened already that county legislators have proposed legislation to give rights to the county to stop clinics from opening up. That's a terrible precedent to set, because then that means any local leader, whoever they may be, whatever time of life or left or right of the political spectrum, they can choose to utilize that and stop these clinics from opening because it's going to hurt the quality of life of our neighborhoods. And that's what I've seen, the struggle statewide. I gave myself a tour my first year as the chair from every corner of the state, from Syracuse to Buffalo to Long Island, all over the city. And that's what I hear, that, we have trouble finding locations because communities will try to kick us out. So that is part of the greater stigma battle that we live in, that, there's still that idea that this is terrible for our neighborhood, we can't have it. But yet these neighborhoods and these communities have high rates of suicide, of overdose, and many times, not what you see outside, but you're finding that people are overdosing and hurting themselves at home. And it's really hard, and it's very terrible. So I ask that, if you ever get in those situations, be one of those, yes, community members that will speak to their local legislators, but to be part of the solution.
Well, I have something to add to your question. I work for Journey Clinical, which allows, I'm a psychotherapist, I own my own solo practice, but I provide ketamine treatment without a clinical setting. So I actually just have my own private office, and that integrates, I think, better into smaller communities because there aren't these big public places opening up. You can actually do these kinds of interventions with your own personal therapist. It can be quieter, more private, everybody doesn't have to know, and I think that is going to allow for a lot more care to integrate into these communities that aren't as accepting of this culturally.
Yeah, I was also gonna add, I think, that was one place that I was going. I think it may take a little bit more time to get there with some of these other substances coming through the FDA, at least just speaking in terms of the medical model. I do worry somewhat about it's called risk evaluation mitigation strategy, or RAMs, that the FDA will put on, require this to be done in certain specialized clinics, and yeah, there's going to be access barriers, and it might take some time for those to loosen, but ultimately I think telehealth and AI and other tools will probably work their way in, even within the medical system. Yes, like you mentioned, insurance obviously is going to be critical, and certainly in plenty of places where the where insurance isn't picking up or there isn't enough coverage, and we're going to see much more state and local experimentation with legal changes to make some of these things more available. And there's different benefits and risks and economics involved in all of that, and I think that's going to play a big factor, but we'll probably see an interesting mix of different potential pathways.
Thank you to the organizers and the panelists. My question is also access related, but access that I think should come sooner in the process, and it's about access for labs that need to do research to understand the way that these substances work. And in the case of these compounds, Dr. Lehrner mentioned that this is not just a compound that a patient is taking, but in the context of a behavioral intervention, which is a very complex system. And for some of these drugs, like for example, Icahn, which has this breakthrough effect for addiction, it's acting through this very complex mechanism that it's not just one part of the brain. So what is being done to address the substances that are on Schedule 1? Should there be some levers or some policy mechanisms to expand and broaden research? What's being done there?
100%. So we've been working on a mix of legislative and administrative litigation advocacy type work towards trying to get breakthrough therapy, things that at least have a breakthrough therapy designation, or that the FDA approves for expanded access, rescheduled from Schedule 1 to Schedule 2, and that would at least ease some of the research barriers. But ultimately, that's not not nearly enough, and there's also a bill called the Halt Fentanyl Act that is, looks like it is probably going to pass at some point later this year that will reduce Schedule I research barriers, but ultimately for these substances that are very easy to access and widely available, like in, particularly in most major places, like you can access these substances. They're not nearly as dangerous as certain others, and so from a policy perspective, like just waiving all the DEA should not even be regulating, in my opinion, the research. If the FDA signs off on a study, like that should be it. You should be able to access drug use. You shouldn't have to go through federal and state related, paperwork and installing these safes that have to be bolted in 700 pounds for like this much of a substance that you could just go get anywhere. It's a huge waste of money, like incredibly inefficient, and so that is a major problem.
And the rationale is that there's a diversionary risk?
Diversion, yes.
And that outweighs the risk of using a substance that's the rationale there is that outweighs the risk of using these substances when we don't understand fully the causal mechanisms. Like, are those two things being juxtaposed when framing this, like trying to relieve?
I mean, this is a Schedule I drug, right? It's like heroin. These drugs are scheduled like heroin. So if I said I want to do research on heroin, I would need to show all the ways in which I'm making sure that that's not leaking out in the community, and that better be a good, I won't say the expletive reason why you're doing that research, right? So the threshold is very high. But in addition to all of the regulatory hurdles and all the three-letter agencies we need to get approval from, which is very burdensome, and in New York State we have an extra one because we have to go through, I have colleagues, for example, on the West Coast where they have a relationship with their DEA agent, they get their license in like no time. But I have to go through the New York State Bureau of Narcotics Enforcement first and then to the DEA, so we have a little extra spice here in New York. But the other piece that is also really relevant for research is research is really expensive. And there has been zero federal funding for research on psychedelics until very recently, and very little. All of the stuff we're talking about has been funded by philanthropists, all of it. And activists who believe that there is potential here. But we've run like 6 clinical trials or something, like not a penny from the government, none. So everyone wants to talk about the regulatory hurdles because they're real, but honestly, like a lot of the barriers, most of the research in the United States, medical and psychiatric research, is funded with federal dollars, and that just hasn't existed.
And I think arguably, at least the Schedule I status has played a factor in the lack of funding for many years, and that is another issue. It also is driving up the cost of federally funded and state-funded research. We've gotten funding in a variety of different states around the country to help start doing these studies, and it's just wasting government dollars basically by forcing people to jump through these hoops. But yes, I agree, and I do think that's one issue that we're starting to see some change on the funding side, and hopefully much more to come. But it's both are major obstacles.
I think this comment is really important for in particular, the natural substances that can't be patented. So if it can be patented, then there is some money because somebody will want to do the research, so it gets approved for an indication, and then it can be used as a medicine, and then it's bifurcated. So the natural, so let's say psilocybin, natural mushrooms would remain Schedule I, but a synthetic would be prescribable. So there isn't a lot of incentive to do research and reschedule natural substances that people can't make money off of just to be crass. But that's a reality. And then the other issue is sourcing, because you have to have a cultivation license for these substances, which is very hard to get. And I think I only know of very few that exist in the US because of that diversion issue as well. So
Or even GMP,
to be able to study cannabis or psilocybin.
It's going to get much more. The legal system's going to get way more confusing. I think there is a lot of confusion over the fact that multiple synthetic forms, or even some botanical forms of psilocybin, are probably going to get FDA approved and be rescheduled and prescribable. And it's possible that psilocybin itself stays Schedule I, or maybe maybe it does get rescheduled, but it doesn't mean that what the, people working under different state legal programs are still violating federal law unless they actually become, registered by the DEA. That's not what I expect is going to be the case with people who are operating in the state legal system. So there's still a very confusing legal and regulatory landscape that's probably going to unfold over time.
Great, thank you guys. Thank you so much to the panelists. So my question is, when we're discussing the medical potential of psychedelics like psilocybin, which coincides with the rescheduling of these substances, how much thought is paid to currently or formerly incarcerated people who serve sentences for possession or use of psilocybin or a similar psychedelic?
I would say a lot is, I don't have the only psychedelic related bill in Albany. There is another one that would decriminalize the possession of it. I appreciate that we always keep that thought as we pursue legalization and any other policy, because you have to address the harms that have been done in the past. You have to address the barriers that exist for various different reasons. So I do believe that, or I would like to, as the chair of this, to make sure that we move forward in a way that is very conscious of the harm that has been caused, and to help people as we're getting into, new policy, to be able to, live their life away from what the current policy and law has done to them. So
One of the bill that I wrote does say that if psilocybin becomes legal in this framework, it would expunge the records at state level for anyone who would use psilocybin, and give them basically tax credits to get them to participate in that system as a cultivator or a service provider. But how do you fix that?
While we're waiting for more questions, is there something that we're missing? So part of this is that you are educating and informing us about this topic. Is there something that we're missing that we don't even know to ask you, because we're not in this world, but we're very much scientists and science policy enthusiasts and want to be involved in it? Is there something we're missing, that we as constituents can help with, or we as scientists and researchers in this field can help with, or future leaders? Is there something we're missing?
So going back to the funding, we just passed the state budget in Albany, and it took a while, but I started the conversation. I'm ready to introduce a piece of legislation to essentially put funding towards ibogaine research. And already I'm getting well, good luck, because it's Schedule 1 and you can't give state funding to research federally illegal product. And that goes back to, okay, our federal government, who's in charge, what's going on there? And right now I am very fearful of what more we're gonna see the federal government do to us, because just in this last 2 months of the budget process, we've gone back and forth. Okay, we're gonna have this much funding for school. Oh my God, but the federal government just, cut dollars. With the budget that I oversee for Office of OASIS, I think it was mid-April that the federal government rescinded a bunch of block grants. And that, puts us into, the real idea is that we might have to come back later in session. Our session is until mid-June. We might have to come back to pass a whole new budget, because all of the lost federal dollars from grants, from programs, everything is gonna make us have to rework our budgets. So that alone is already has, the counselors and legal counselors telling me good luck ever trying to get money for research, because now we need all this money just to have programs, stay alive, to stay open. So I asked that, do something in 2026 to make sure that, there's more balance in federal government.
Yeah, so just to clarify, there can be state funding of Schedule 1 research, but it does have to be compliant with federal laws and jumping through all of the different regulatory hoops that Dr. Lehrner was mentioning. So we have gotten some of that funding, and even maybe some state funding, from Texas at least, and maybe some others will go to ibogaine at some point, potentially very soon in Texas. The FDA is another giant hurdle on that front, unfortunately, because of the safety risks. But yeah, ibogaine is certainly an area of incredible interest for both traumatic brain injury and a variety of different neurological conditions, opioid use and other substance use disorders, and yeah, we're excited to work together to try to help.
I mean,
bring
that
some of
was
company
exciting news to
forward.
me that Texas took that step with the ibogaine conversation, because you think of the red state, oh my God, nothing happens there. Why in our blue state, New York, are we afraid to enter the conversation? So that is something I'm gonna be using in my, conversation pockets. If Texas could do it, why can't we do it in New York?
And they're already funding psilocybin research.
Exactly.
Science offices doing that right now.
See, putting politics aside, put policy forward. Both states can do it.
Question. I know that, I think the NIH put out a few years ago, some big meta study showing that cannabis is effective medically. There's tens of thousands of scientific papers out on cannabis. I assume, I know less about psychedelics, I just have researched cannabis. And so even if you pretend that none of those studies exist, the anecdotal data is just so outrageously ubiquitous. And so I wonder, Dr. Lehrner, you said something earlier about more research being needed, which obviously more research is needed. But at the same time, is there some ethical problem knowing that it's so effective, and at the same time dealing with this legal minutia essentially of trying to, this absurdity that we're all in legally? Are there other pathways, is my question, to making more people able to access, these substances medically by educating more doctors, paths that do not include dealing with the Schedule 1 nonsense?
I do think that we have to think about what does it mean to know something or to have evidence, because you use the word anecdotal. That is true, right? Like anecdotes
But
are
it's so
powerful
overwhelming.
stories. There is a lot of it, but also that's not science. So you guys are scientists and policy experts. We want to listen to what we're learning from the field, but if you are a science policy person, you should put on your research methods hat and think, well, what are the potential biases of that source of information? Am I hearing from the people it didn't work from? Am I only hearing from the people who work? What about the adverse events? What about vulnerability and sexual assault that happens when people are under the influence? What about so I mean, here I am. I'm usually in a position saying, let's talk about stigma, let's talk about all the potential for research. But this is a science policy group. We do need to think about not getting ahead of what we know. When we talk about what we know, we have hope, we are enthusiastic, there's lots of anecdotal evidence, but there's anecdotal evidence for lots of things when you look for it. So I think that your question, we have so little research. There's actually a very small evidence base for each of these substances for different, we're really building a lot on not that much data with psychedelics. And we don't know who do they work for, in what setting, with what therapies, with 2 therapists or 1 therapist, how much integration is needed. There's a million questions. Who should be excluded? Are we screening people, with backgrounds where they're at risk of psychosis or mania? There's so many things that we don't know, that we kind of need to know. What models are gonna work best? We actually have no idea. We have no idea. And there's this ethical question of science is really slow. It is really slow. And the more expensive it is, the more hurdles, the slower it gets, right? You really need to work for a place like Mount Sinai where we do cutting edge research and we've got all that infrastructure, and it really limits, what about rural areas where they want to do research and they just don't have the infrastructure. So I feel that tension of the ethics, which is why, you mentioned Jesse, programs like Heroic Hearts wind up having to send people overseas to retreat centers outside of America to get healing now, and that's a travesty. So we do need to be trying to find ways to create these pathways, and at the same time we have to balance that we're still learning about the potential harms and how to provide these treatments effectively. So I hold that tension in my heart. I work with patients who I've seen what these treatments can do. So I don't know where the right balance is, and I think that there are opportunities for things to be loosened. For example, there are ways that, what's it called, expanded access, right? There, or whatever they call it in the United States.
The expanded access program or right to try,
Right.
which is blocked by
Right.
Schedule 1, right?
So there's expanded access for MDMA, that there's some sites doing it. So in other words, because these drugs were considered breakthrough status, there are mechanisms where they can be offered to people in the community with a lower threshold than like these very rigid, like randomized clinical trials. But they still limit the number of people who can get access to these medicines. The other pathways are through non-mental health treatment pathways, right? So all the different states that you guys have talked about, kind of right to try through religious and spiritual organizations, local areas where decriminalization has happened. So these are other pathways for people to get to these medications. But then what we don't know is, like, what are they actually taking when you buy something off the street? What happens when people have bad experiences? I mean, you know, we have groups like Fireside Project, they're just doing harm reduction and dealing with people having terrible experiences or traumatized by what happened to them, and we need more programs like that. So people just taking psychedelics without a safe container, without any place to process that is risky. So I think we have to we're so desperate for new treatments and for healing and for care, and yet we have to also be careful because do no harm is our first role, right? So I think it's something to hold in tension.
Kind of getting back to how people can get involved, also especially the science angle, it is very difficult to do research on botanical and other like plant-based products. Most of the drugs that go through the FDA are synthetic, good manufacturing practice medications, and I mean that is one area that maybe the new administration I think is probably much friendlier to exploring, some potential FDA reforms to make it easier, and that is an area of potential advocacy. But funding is needed because of the often lack of patent protection and some regulatory changes, a stronger focus on, some of these naturally available substances and in that actual form, not the synthetic formulation.
To expand on David's point, and I understand the whole thing about things being anecdotal, but has there ever been a serious survey done of psychiatrists, psychologists, and patients to get some kind of, turn the anecdotal into the scientific?
This is a specific kind of research. Actually, it's called naturalistic data, and it is this potential bias, like who's responding to that research, but they can collect data from people using it outside of a secure clinical setting. I think it is data. I mean, we know that that's possible. FDA has actually done research on some of the communities that use ayahuasca in a communal spiritual setting, and that's been approved. So that makes it federally legal. Some of them have exemptions, and that actually has been showing a lot of health in a communal use, right? That's ayahuasca. So could that be done in other settings? It's possible. It is really difficult. You do need the funding. Is there bias? And it's a lot of complicated stuff, but I think what we note with cannabis, what was so interesting is HHS recommended rescheduling, and it's just been sitting there. And a lot of it is bureaucracy that really does get in the way. And I think I can say this as I'm not a doctor. If you look at how the schedules are defined, it is quite unrational the way that some of these substances are put in Schedule 1 instead of at a lower schedule. I think a lot of it has to do with UN treaties and a lot of the history of how different races and other foreign communities were treated as they came in with these substances to the US.
Can I just follow up one more time? Do we know how many mental health professionals are using these substances who might be surveyed? Is there any? Does anyone know that number? And are there any countries where these things have been used for a long time because the countries have less absurd rules about drugs? 2 questions. That's it.
I think you definitely can track the research, but
I want to make sure I'm following. So when you say medical professionals using these substances, you mean providing them or treating people with them or taking them?
No, I mean people who are using them in a professional sense
Professionally,
on the patients.
that would be 0 in the United States because it's not legal. So no medical professional, unless they work for an FDA-approved clinical trial, is providing psychedelic substances to patients. If they do, they're doing it what we call underground, which risks their medical license as well as, you know, other kind of legal consequences.
But then what about ketamine?
So ketamine is the exception because it's being provided off-label.
So do we know how many doctors are prescribing ketamine?
Ketamine treatment, I don't know if you know how many.
I would say it's growing, because of, the Spravato and because of, it's Schedule 3, so it's been studied extensively, so we know a lot about it.
But not for mental health.
Not so much for mental health, anesthesiologists and emergency room physicians use it daily. So they've kind of become psychiatrists as well, you know, and using it for mental health purposes as well. So there's a lot of exposure and experience in that regard. I don't know, but I think Colorado and Oregon, it's legal psilocybin to use. I don't know if their programs on the state level have been rolled out yet. I don't know.
Oregon, yes. Colorado's, the regulated framework is still coming out, but personal use is decriminalized, which is just kind of more gray area.
So very little, you know, in controlled settings that we have experience with, you know, classical psychedelics. But there is some hope. I think, Brett, you were referring to the synthetic forms. So there are publicly traded companies that are in late-stage clinical trials with several analogs, say, of the parent compound, that are going through the traditional FDA approval clinical trial studies, will present data to the FDA when they're available, and that may improve access as well, because that would be considered a regular pharmaceutical, so covered by insurance. So I'm hopeful that we'll see that one day.
I think you could say, you know, Ibogaine is used in Africa. It's been a traditional medicine for a long time in ceremony, and in Jamaica, psilocybin is legal, and in Brazil and Peru, particular uses of ayahuasca is legal. Indigenous use of psilocybin in Mexico is legal. So there's little pockets.
Australia also was the first country to legalize MDMA, and so they're kind of going to be generating, I assume, more data as well about clinical applications. But it turns out that it's complicated there, and it's not so widely available, and it's still highly regulated. But there will be more evidence coming from that.
That's
Potentially
medical.
useful.
Medical,
But that's
yeah.
medical. I'm talking about
Right.
other.
I have a question. What do you guys think about RFK Jr.? I think he's an ally in this issue. Do you think we can get past the left-right divide and he can actually be a very useful proponent of getting these things approved?
I mean, he's an interesting guy. He just said don't take him for medical advice, you know, so maybe. I'm not gonna lie, I have appreciated some of his conversation about, like, you know, the dyes in food, and even having Coca-Cola use, like, you know, different sugar. So I could say he could be, you know, at least someone to start the conversation amongst, you know, his peers up there. But I'm not gonna trust him.
I think we can speculate anything about this industry.
Yeah, it's been a surprise every day.
But I do think that one thing that is really helpful, I think, around psychedelics and the advocacy around psychedelics is that it really hasn't had that red-blue divide, and partly because you mentioned so much advocacy in the veteran community, I think. I mean, Texas is doing it, so there's great parity, you know.
Crenshaw is actually a big supporter of psilocybin.
So it is maybe a helpful moment when politics is so divided and science is being so denigrated that, you know, there might be an opportunity for us to all come together to promote the science and healing across any political divide. So I'm hopeful for that.
It's also, yeah, I certainly think, you know, we're seeing a better trajectory of funding hopefully on the way. But there's also other regulatory changes that don't necessarily have to be specific to psychedelics, but they're just helpful for deregulating, whether it's controlled substance research or certain changes to the FDA that could end up being helpful but it doesn't even have to be specific to psychedelics. But yes, overall, I think we certainly notice statements have been positive.
I think we have no more time for any other questions. This has been a really great talk, and I want to thank our panelists so much for attending. It's been a very interesting discussion. I've learned a lot. I hope you guys have too. Is there anything else in here?
Thanks for coming, everyone. Thank you.
Yes, and we still have some food left, and please, you're welcome to mingle with each other.
And then also, before we close, does anyone on the panel have any last words they'd like to impart to the audience?
Thanks for your interest, and I think that comment earlier about the question about how to be involved advocacy-wise, there's so many groups involved, so I would just encourage people, wherever you live, or if you have a topic, you're interested in PTSD, or you're interested in Icahn or something, find the organizations that are working on this. There's so many groups that you can join and lend your voice, because it really has been advocacy that's moved this field forward. It wasn't the scientists leading, and it wasn't the politicians leading. It was the community leading. So that's just going to continue to be really important.
Come to Albany. Know that our legislative session is January to June. Do your research now to know what policies you want to advocate on, but speak to your legislators, make appointments with other legislators, because the more that they understand and know the facts behind it, the more we can move forward in trying to see some change. So yes, please stay advocating.
Please join New Yorkers for Mental Health Alternatives. We have lobby days up in Albany. We can hang out with some panelists.
The officinas su oficina.
All right, let's do one more round of applause for
Thank you. Yeah, grab the last munchies. And thank you for watching live.
Oh, good ending.